Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
It has been a while, and today we're going to talk about traumatic wound management. Today I'm sitting with three other fellas, and how about we go around the room, introduce yourself.
Okay, I'm Rick Hines. I'm instructor at the SFMS refresher course. Retired 18 Delta.
I'm John Johnson. Not retired, but I am an 18 Delta. I'm the chief instructor here at the Special Forces Medical Sergeant refresher course. About another 15 years before that in the 5th Special Forces Group. Got a decent amount of experience across the board.
My name is Justin Rapp. I'm currently the NCOIC of the Special Operations Forces Austere Care Course, run out of the Office of Special Warfare. I'm an 18 Delta as well.
Awesome. So today, what I'd like to do is go through the new wound care CPG and see if we can distill it for all its goodness. So I'd like to start off with Justin. You're on one of the authors of this. When do you foresee people actually using the information out of this CPG, going from T-Tri-C through PFC?
Well, again, the approach to this CPG was absolutely in the context of a prolonged field care situation, which means that we've more or less eliminated life threats on the X. We've gone to a certain level of evacuation care to mitigate any potential future insults to the given injuries that we have. And now we're in a clinic of some kind. We're not on the X with a lot of peripheral distractions going on. We're in our clinic. We have some resources, and now we can take a good look at the wound and see what is simple about it, but certainly what is complex about this given wound pattern.
You know, how do you guys go about just evaluating a wound, and how are you going to make your decisions going forward?
So the first thing I do whenever I look at a wound, once I'm under some bright lights, is I ask myself, I take a very close look at the cavitation, because I really want to get a good picture of what that wound looks like. And generally speaking, in order to do that, there's a certain analgesia strategy that you have to apply to that for the patient so that you can manipulate the wound a little bit. Certainly not grossly, but so you can see what the true damage is of a wound. Obviously, combat war wounds are complex wounds. They're often not very simple. So I like to get a good analgesia protocol on board, some oral analgesia. And I'm a big fan of local. It's simple. It requires significantly less equipment. Regional, I know, is coming into a lot of favor, and people are getting better and better at that. I'm okay with it. Certainly with some help and some guidance, I can do that. But when we need ultrasounds and additional equipment and drugs, that starts to make it more complicated. So in my experience, I've had a lot of success with just using local anesthesia, lidocaine, with or without epinephrine, preferably with epinephrine. And so I like to explore the wound, do some more wound exploration to see how bad it is. If I'm lucky and I'm fortunate, I'm the one who treated him on target or at the point of injury, so I'm able to have some context for that injury. I get some good analgesia on board. I wait till the patient is not feeling so much pain, and then I explore the wound to see how bad it is.
Okay, what are you looking for?
So what I'm looking for primarily is, first of all, is gross contamination. That's the first thing I want to get out of there. I like to wash it with soap and water, regardless of what is in there. Pull out any sticks, foreign bodies that I can see that are large. Pull all of those out and then wash it with a good amount of soap and water. And then I just like to see if that soap and water is getting out those splinters and those smaller pieces of contamination so that I can look at the wound. I'm looking for the contamination, obviously, but I'm also looking at what damage that I've done to the tissues.
So one thing I've noticed too is, depending on what time you learned a lot about surgery and debridement as a whole, there's some mixtures of ways to look at it. So I know when I went through, we looked at a lot of using the irrigators, the pulse irrigators and things like that. So that's one thing I definitely like to talk about when I teach the course is the avoidance of those pulse irrigations as you're doing it. A little bit of pressure, just hand pressure using an IV bag or something is fine. But anything stronger than that, you just end up pushing those gross contaminants back into the body deeper than you want to be able to have to dig them out. So that's one thing. Another thing is keeping in mind the temperature of the water. So you don't want it freezing cold, obviously, because it's going to cause some other issues with the patient. and it's hypothermia. But warm water is not going to be your best option either. You want that lukewarm, out of the faucet type water, which is a good segue to my next piece. All right, so I know a lot of us tend to not have a large amount of fluids on us, but if you can drink the water, it's safe enough to irrigate with. So that's a big piece, I think, when we're talking about irrigation. And I agree with Justin, though. Like, the key is identifying how big this wound really is, how deep it's going, before I really get into the decision-making matrix of, am I going to debride this? Am I going to try to go deeper than what am I actually dealing with? And as far as assessing it, the next thing you touch is your 4 C's. So, color of the material, or the tissue itself, you want to look at that, right? It's the least reliable, so you've got issues with the fact that it's probably going to change color just due to the oxidation, and it's going to change colors because of the materials you're using to clean it, whether you're using betadine, soap and water, chlorhexidine, all these things can kind of change the color a little bit. So that's your really least reliable, but it's still important. The contractility of the tissue itself kind of tells me a little bit more about it, the consistency of it, and then the circulation that it gets.
Capillary bleeding?
Yep, which comes to capillary bleeding. Like, how do I know, is it getting circulation or not? If it's not going to have any capillary bleeding, then I know it's bad tissue and it's going to have to go. And that gives me an idea of how much I'm going to cut out before I get started.
Okay.
So, you mentioned that, depending on when you went through the course, years ago, they taught P for plenty, right? When in doubt, cut it out. Now we're teaching a little more judicious debridement, more strict adherence to the 4 C's. What I found is the sooner I do a debridement after injury, the more I end up having to debride. And the reason for that is it takes time for that tissue to hematoma, to show those signs of damage. So I really can't tell where that line of demarcation between devitalized and vitalized tissue is. So I end up having to debride a little bit more, because basically, I mean, let's be realistic. We've got one shot. If we have to debride again, we've made a grave error, and we've really screwed up with the patient and with our resources. So we want to get it right the first time.
Okay.
It's also going to throw off our timeline. So we only have so many more days we can wait from the point of injury to being able to actually conduct a delayed primary closure. So if we have to go back in when we open it up and debride some more, now I likely will have to do secondary intent and not a delayed primary closure, which decreases his ability to heal quickly.
And it increases his convalescence time.
Right. If I can, I want to step back quick. We're talking about irrigating. So, when I went through the course, we got a great big basin, and we just kept squeezing water into it until the basin was empty. How do you determine how much irrigation you need to give? Because at some point, you're now just wasting time.
Right.
And you're wasting some kind of resource.
So a good rule of thumb is 3 liters. That's where you really kind of want to start your mindset at. But what I really do is look to see what's coming out of it. So as I'm irrigating, I'm looking at the color and consistency of the fluid as it drains back out into that basin. And as it gets to a more Kool-Aid looking, like a very pink lemonade type color, then I know that all the bulk of the dirt and nasty is coming out, and it's really more so a little bit of capillary bleeding and fluid.
So
that's kind of what I'm going for.
For us, the textbook answer is 1 to 3 liters. And that's going to depend on the size of it. I like to get my fingers in there, get all the compartments open, make sure I irrigate every crevice that I can. To make sure that I didn't just push stuff back in the back there, that it's all coming out. I like to open it up and look as much as I can.
Okay. Do you have any rules of thumb as far as size? To say this is a small wound, this is a large wound?
There's various, when we say small, medium, large, it seems very subjective, and there's various studies out there that suggest different sizes of wounds, and they tether an amount of fluid to those size wounds. For us, and what I believe is the most important is that we consider in an austere environment, all wounds are generally going to be contaminated with something. Whether we can see it, and more scary is what we can't see. So in terms of doing, like the book answer being 1 to 3, some of the research I saw out of the Wilderness Medical Society, they've found that more than 9 liters of fluid generally does not produce a better outcome. So as you work up to that grossly contaminated and or large wound, whatever we deem a large wound, 9 liters of fluid generally does a good job of irrigating. And so what we kind of are talking about in terms of a overall approach to wound care in an austere setting, I think it's important to note that what we're truly trying to do is doing a lot of infection mitigation. And the best outcome for the patient certainly is infection prevention. And from an irrigation approach is the type of fluid we're using, the pressure we're using, and then how much. So something maybe to mention is that additives such as iodine, bacitracin, or alcohol are not associated at all with reduction in infection incidences. Very high pressure, we used to kind of think that, if I can squirt a lot in there very quickly, that it'll blast that out. But anything over 15 psi is generally regarded as potentially dangerous and pushing infection into the wound. So something in terms of, since we talk about prolonged field care, we're generally talking about an austere setting. Something that gives you a general sense of it is around 19 gauge, which is a rare catheter. So around a 20 gauge catheter with a 35 milliliter syringe will deliver approximately 8 psi. So you can go up or down with that. Like John already mentioned, we're looking at, body temperature, cooler water or fluid, not something that's hot, certainly not something that's going to damage the tissue. And then in terms of the amount we already mentioned, 1 to 3 is usually a pretty good starting point. And then nothing over 9 is going to do much better for you.
Okay. As far as timing goes, when you decide to do a debridement, do you want to have resuscitation done with, or do you err on the side of cutting it out early?
In my opinion, surgery, debridement is a planned event. It's not an emergency. So the patient should be as stable as you can get them. Your damage control resuscitation should be done, your telemedicine, everything. And now, okay, I can't get this guy out to somebody more competent. So now I'm going to plan the surgery. Now, this is not an emergency. You could plan it for tomorrow. It can wait. You've got all the life threats taken care of. If you decide that sooner is better than later because the longer you wait, the more unstable he may become, then that's a choice you have to make at that time. But debridement's not an emergency. So it's after DCR, after damage control, resuscitation is complete.
Yeah, basically just treat it like you do a lot of other things where you measure twice and cut once. In this case, you plan early and operate when appropriate. So plan for the surgery. As soon as you know you will likely get into that situation. So as soon as you have a patient that's going to need a debridement, you plan for it, simultaneously trying to find out if you can get them out of the area and somebody more qualified can do it. And if not, then you're ready and you can get into the process of doing it properly. So you're not rushing through. Mm-hmm. And like Rick already said, it's not an emergency, but it is important to get those contaminants out. And the other piece of that, the reason it's not as much of a rush, is there's never a contraindication for secondary intent closure-wise. So if you just took too long to get to the point where you could cut and do the debridement, you can always close by secondary intent. It just takes longer. So you don't have to rush to make sure you're fitting in those proper windows to do the lid product closure.
Yeah, I think this absolutely speaks to the problem list development and really developing that good problem list for long-term prolonged field care. And certainly, going categorically down your problems, you can say wound care. It can be as simple as that. If you want to break it down, wound irrigation and debridement, and then certainly a problem set that you have to address probably a little quickly. I completely agree with them is resuscitation. And what is your plan for that? And then executing that plan. The debridement and the wound care it's not an emergent thing as resuscitation potentially can be in the long-term effects of poor resuscitation, certainly in a clinic environment.
I think also if you do a good job with your resuscitation, deciding what to cut in your debridement is going to be a lot easier. If you do a poor job resuscitating or you're barely able to achieve your resuscitation goals, you're going to end up cutting a lot of tissue out that didn't need to be cut out just because he wasn't resuscitated yet.
Yeah, I think that's a great point, because like circulation or, the capillary bleeding is one of the number one, pieces that we use. And if he's more shocky or has less blood because we haven't resuscitated him, he's not going to be bleeding in those capillary flows as much as we thought he would.
I can tell you, if you wait 24 hours after a wound occurs, that seems to be a really good time to start thinking about doing a debridement. Anything sooner, and we end up we don't get as much discoloration in the tissue as we would have at the around 24-hour mark. So, I mean, that's not a hard and fast. That's a fluid, but the closer you do your debridement to when he was wounded, the less you're going to be able to tell those lines of demarcation between vitalized and devitalized tissue. So you're going to end up possibly either cutting out too much or not cutting out enough because you can't tell. So that's another reason to, yes, clean the wound, by all means, dress the wound, and do your focus on resuscitation, and then take a breath and plan the surgery.
Yeah, certainly when you're debriding a wound, it's not always that wound where you have to put the patient on the surgical plane. It's still a minor surgery. We're still using surgical techniques on a wound. They're just not always that very complicated wound where you're debating whether you're going to amputate or something like it. It could be a large part of meat missing out of a human being's leg that you just have to go in and clean up the surface area of it. And so, like I said before, I've had great success with just local anesthesia in terms of taking care of those patients, possibly with the application of some ketamine so that they're not thinking about it so much. I think there's absolutely a place for some morphine in this with a hemodynamically stable patient. I have an opioid that lasts a good long time for that. And when I go into debride, in the past, what I've learned is if I can get a great deal of the gross tissue that's been destroyed and that is not viable out, but maybe I don't get all of it out, and I'm there taking care of my patient in a prolonged field care setting, I can see him again the next day, and there's a potential for me doing a minor surgery, to doing another applying another local anesthesia strategy to getting some of that stuff that I was questionable about. And I learned that is actually something that you can do, whereas when I was taught initially in the Delta course, it was really important to do the P for plenty. I come from that generation, and I learned over time that I can save a lot more tissue if I just have a very measured, I kind of like that word, a very measured approach to my debridement and my wound care. A war wound, again, is complicated. It is going to take time for that thing to heal, and also it's going to take time for me to apply quality treatment to that patient.
So, yeah, I'm glad you mentioned that, because that kind of brings into effect the difference in thought between an FST or a CASH and what we teach in the course with the ICRC protocols, or their recommended war wound treatments. And so what we're looking at, in the course, we teach the ICRC version of war wound treatment because we feel it kind of fits more into the way we operate. So we have, especially if we're working, if this is a host nation patient, I don't have the resources to house him post-surgery. So I'm going to recover him, and chances are I'm going to send him home for a few days and have him come back in a few days, and then I'll check his wound, as opposed to, Q24-hour wound washout, redress, or twice a day, dressing change or anything like that. We don't have the resources to do that, the manpower or anything. So that's kind of why we lean towards the ICRC model. Granted, if you do have your patient that stays there with you, there's nothing that says in 24 hours you can't have a peek and see how he's doing. And if he needs a little more tissue trimmed off, you can sedate him, do a regional, do a local, whatever works, and go in there and clean it up.
And we have found that by not changing the bandage every 24 hours, we've actually drastically reduced our infection rate. So when we were training, I think Justin and Rick and I all trained in the same time frame where we were changing bandages every day. And we had a pretty high infection rate oftentimes. And we just assessed in the beginning that we were just young, we're learning, we're making mistakes. But as we've learned, that's probably partially true, but the bulk of it is that we're exposing that wound to contaminants that we don't need to. And by keeping it wrapped and closed and waiting 3 to 5 days before we do a bandage change, we've actually drastically reduced to a point where I think it was 70% or higher for a long time in the infection rate, and we've got it down to about 0.2%.
Really? I mean, that really comes to the important part. You know, it's one thing to say we've adopted this protocol because it fits us. That's another one to say we adopted it and it actually is better than what we've done previously.
I don't want to beat everything down too hard, but before we get too far, as you're taking care of that wound and doing the debridement, I think it's important to remind all of us that ligating vessels is way more important than using some of the more convenient tools like electrocautery. I know that they're travelable, I know that they're shrink down and they're easy, but by burning anything inside the body, you do increase that opportunity for infection. So if you have the skills or the time to ligate, please do so. If not, you can use electrocautery, just be careful and be measured. That's a great term in your decision.
So after going through your debridement, now it's time to dress the wounds. What kind of dressings have you found are most successful?
I think it's just important to start off with that nice matrix. So you take, a piece of gauze and make sure you have a sterile piece of gauze that you can open up all the way, so unfold it completely, and it gets that nice kind of wavy look to it. And then crumple it up almost like a loofah, and you can push that into the.
I don't know what a loofah is.
I like that. Do you use loofahs?
I loofah myself.
I have a loofah.
I have to exfoliate.
Basically, you just want a nice, airy, fluffy pile of gauze that you're stuffing in there, and that allows the wound to kind of adhere to it just enough so when it's time to take this bandage off.
And you're not packing it. You're not pushing it in. It's just placed over the entirety of the wound on the surface, and then you put your bulky dressing over that. And what we've seen, we let it sit for about 3 days before we even changed the dressing. And like I said, our infection rates have dropped drastically. And then when we open it up, it's to make a decision: do we need to redebride and let this close by secondary intent, or can we close this now? Is it infection free, and can we close this one? So an important part of that is when you peel that dressing off, when you do that next check, you want it well adhered to the wound. You want that granulation to have formed into that matrix. And one of the first things I look at is my smell. So we tell the students there's a good bad smell and a bad smell. The good bad smell is the ammonia. It's a kind of ammonia type smell. That's what you want. If it smells like rotting flesh and the bandage just sloughs off and there's a bunch of goo there, well, that's obviously bad. And now we're going to have to do a lot more work. And so that's kind of what we look for when we do that next bandage check. And what you expect to see if everything's successful is capillary bleeding. Good, healthy capillary bleeding and nice marbled meat that you want to put on the bone.
I don't know if this is taking a step back or not, but in terms of doing wound management and that problem list development, I'm a firm believer in the problem list because that's what organizes our thought. We go all over the place here talking about the different prongs of wound management, but in terms of the way that you approach a wound is that problem list. And as soon as I see a wound, I immediately write down wound care, pain, I write down infection, and then I write down nursing care. And those are sort of the 4 prongs that sort of encapsulate everything that I know. And if I do a very diligent job at each of those categories, then I'm going to be pretty successful, or as successful as I can be in terms of managing that wound.
Okay.
No, I totally agree. Your nursing plan is key in your patient's health. It is patient care. It's, a lot of guys are like, nursing, whatever. Yes, it's nursing, and, get over it. But it's patient care. It's the wellness of your patient. And that encompasses everything from brushing your patient's teeth if they can't do it themselves, to sponge bath, and all of this stuff, though it sounds like it's a real pain and it's arduous and tedious work, will save you and your patient work and suffering over the long term.
Another question about dressings. Do you cover them with like saran wrap or anything else?
So no, I don't use any saran wrap. I found any kind of plastic, to be honest, is something that, although it sounds a great idea, and I've actually debated it a couple times in my career in the desert, to keep a lot of the outside contaminants in, what I found is it is way better at keeping the bad contaminants that are already in the body in a dark, happy place where they'll grow and become very infectious very fast than it is at keeping any of the dirt and other contaminants out of the wound. So some Kerlix is something that we've all carried for long periods of time. It's an easy bandage to apply and wrap around there, or some 4x4s, a nice bulky stack of those works great. I've got no issues with maybe using some Coban to keep it on there, because I know that Kerlix doesn't stay very well and it kind of has some porousness to it. That seems to be a pretty good job at keeping the bad out, but not encouraging the bad to grow inside. But plastic, saran wrap, things like that are very dangerous.
So the exception to that is if you have some type of wound vac, then you have a means to draw. And we all know that wound vacs are magic. And we also know that we don't get issue those. Right. You can kind of jerry rig one in the field if you choose to do so. And
which is in the CPG using your suction device.
Yes, yep. Exactly. And
there's a couple other good options out there.
And so that's the one exception. If you can provide that wound vac type of effect, then by all means. The other is we'll mention later with like honey dressings and stuff like that. Then you do use some sort of non-porous cover over the bulky that goes on, or the formal dressing. Yep.
So I definitely come from a generation where wound vacs were not taught in the schoolhouse, and that was something that was very foreign to me. I know I'd seen them in hospitals before, but on my last rotation, there was an FST co-located with us, the 629th, which was absolutely a luxury, and I had the opportunity to learn a lot. And of course, they had small wound vac machines that were actually no bigger than a ball cap, and they provided consistent 120 millimeters of mercury suction on a wound. And I didn't know much about them. So I wanted to learn about them. So I dug into them and I started applying them to the war wounds that came in. And I was amazed at the speed with which wounds healed. It was significantly different. And we approach this wound care with certainly like a hallmark of good wound care is infection prevention and mitigation and treatment. And I forget what the statistic was, but wound vacs greatly reduce the likelihood of infection in a wound. So I'm a very big fan of them as a ground truth medic. I use them every chance that I got, and I got a lot of great results from it.
Now, I was introduced to them when I did a rotation up at the Baltimore Shock Trauma Center. That was the first time I'd seen them, and they were absolutely magical. And then when one of our guys was wounded in Afghanistan, the FST had used that, and I'm a big fan also. But you have to have the equipment to do that, and like you said, using your suction device if you can. If you only have one patient and you can dedicate that to, by all means, do it. It's definitely worth it.
And it just goes back to Justin's measured plan ahead of time, right? So you've already written down your you plan on accessing it, you plan on exploring the wound, you plan on irrigating it. Through all that process, you'll go, okay, how am I going to manage this patient? That's how I'm going to do it. And that's based on all the things we talked about, and then my expected next patient income. If I expect to receive a whole bunch of patients soon, I might not want to donate my entire suction device to this wound when I could simply bandage it.
And you can always change your mind if you need to. So you put the suction on, and oh crap, something happened. Now we change plans.
At some point, we're going to have to talk about antibiotics. While still doing the right thing for my patients, how can I approach this antibiotic therapy?
We treat empirically for the most part. So we make our best guess, whether it's aerobic, anaerobic. where it is on the body, and then we look up. We use references. We use the Sanfords or whatever reference you want to do. We look it up on the app on our phone, and LexiComp or Hippocrates or whatever, and you look up, and then out of that list that you just looked up, you look at what you have, because you're not going to have everything on the list. And when I pack out with that in mind. I can't carry everything, so I may pick a drug that's second or third line of choice for certain things, but it's for many things, as opposed to the first line of choice for this one thing that I'm not even sure is going to happen. So that's the approach I use. And we look at broad spectrums, but those are great. Our references, our TMAPs, war wound therapy, all those are great references. You got to do your homework, though. What's endemic, what's most likely, what's most dangerous, your kind of risk assessment there when you plan on what you pack out with, and then know how to use that.
When putting the CPG together, we had a conversation with some antimicrobial experts, doctors, that was put together by Colonel Shackelford, and there were 5 of them, and then I was on the phone with them. Kind of funny dynamic. But they had a conversation for about an hour, and they talked about a lot of different antibiotics, ones that I've never heard of, and the conversation was generally over my head. And at the end of it, they asked me, "Hey, Justin, are you getting what you needed?" And I told them no, I wasn't. I said, "Could you guys do me a favor? Could you help me out maybe between 5 and 10 antibiotics? Name me 5 to 10 antibiotics that I can give to generally healthy human beings that are going to take care of 90 to 99% of everything." And all of them agreed that they could do one better, that they could give me 3 to 5. And in terms of their 3 preferences for being able to take care of everything was doxycycline, ertapenem, and levofloxacin. They all pretty much agreed that in terms of going down the Levaquin road, that we're not PO levofloxacin certainly doesn't have the efficacy of IV levofloxacin. So they erred on the side, if you were going to bring the biggest gun possible, have IV levofloxacin. That requires some educating, because that requires a certain protocol for administering that. But if we back up a little bit and we start to talk about Doxy, we all know that Doxy is a very effective shotgun blast, takes care of a great many things, and it's prophylactic in many cases for malaria. And then we start going down the road of ertapenem, which is our Invans. We're very much comfortable with pushing Invans. That's every 24-hour over 5 minutes IV drug that most of us carry, the reconstitutable version in an aid bag of some kind. So those are all very familiar drugs to us. And then we add this levofloxacin. You can do it, and you can get pills of it. And I think maybe if you're going to just take it a step further, maybe you do bring the pills. But levofloxacin has been shown to be very effective against Pseudomonas, which is certainly a very difficult bacteria once it takes hold to take care of. The last one that we went down the road of talking about is they were actually all very big fans of moxifloxacin, Avalox. That is the antibiotic that's commonly found in the combat pill pack. So the conversation was very good in terms of finding applicable and commonly found antimicrobial therapy, antibiotic therapy for war wounds that many of us are familiar with. And they said beyond that, we're getting very much into the weeds, very much in the specifics of dealing with that 1 or 0.5% of the patient population who do have an infected wound. And all of those are actually outlined in the CPG. There's 4 of them that are specifically highlighted, and that's the cefazolin or Ancef, moxifloxacin or Avalox, levofloxacin, and the PO is the only one mentioned in the CPG, and then ertapenem or Invans.
All right, very good. Is there anything else that we want to put out there?
I think it's important to just kind of highlight again. Rick talked about it a little bit. Justin's talked about it. A lot of us don't necessarily always carry our entire lab set, and that's totally normal and understandable in different situations due to size and calibration. But traveling without CPGs, traveling without documents that are like the Sanford Guide or the other many guides that we have for our medicine is definitely something that's just not acceptable. Because when you do get in this pinch and you start having to do these plannings without those, you don't really have a starting point. And so it doesn't matter the tools, it matters your mind and your planning ability is really what's important. And then a piece that we didn't cover a whole lot in any of this is that early prep of proper draping and staying sterile, which is, I think, equally as important as the antibiotics you choose. If you can't stay sterile while you do this, or as sterile as possible, and you can't recognize those importance and admit to yourself when you make mistakes and break sterility and go ahead and fix that, you're going to have infection no matter how hard you try. So those are the pieces I think that are important to remember.
So remember, infection equals more dead tissue. Infection actually destroys additional tissue that might have been saved. So with that in mind, should you get infection, remember, you've got options along with antibiotic treatment, redebridement. You can use honey dressings, sugar dressings, sugar dye, sugar and betadine, iodine mixed. These are different techniques that can help you with wound management there.
I guess if I was going to highlight anything additional for this is the context of being able to take care of a wound in an austere setting. We were having the conversation before this in terms of logistics. How do you pack out for this? And packing out is absolutely preparing for it. What are some of the criteria in terms of packing out? And sort of the criteria, the way I approach what I'm packing out, because again, bringing your lab set is awfully difficult when it's either your lab set or the Xbox that's getting brought. So I asked myself, what can get resupplied and where? How difficult is it to get resupplied? What can be improvised? And that is what is replicatable. Bandage, sterilization, and again, the cube space, of course, is always when you're given one ISU to take overseas per ODA, then obviously there are going to be some sacrifices made, most often with the medic in their tac set. But in terms of improvisation and what can be replicated with, instead of bringing it, what can I get when I'm there and how can I make it, about 100% solution in terms of the austere setting. So we talk about, one of the big things we talk about is cleaning versus disinfecting versus sterilizing. If I have some tools, and we all talk about that lobster pot, that large sterilizer that nobody really wants to bring because it is large cube space, and that makes sense. We can sterilize using dry heat. Dry heat is an oven. In the CPG, it outlines, for example, at 180 degrees centigrade, 356 degrees, which is reasonable for any home oven, you can put your tools in there for 30 minutes, and that is equal to sterility. It's definitely on the best. It is actually underneath the best criteria. We followed the minimum, better, best. So that kind of speaks to how effective dry heat truly is on sterilizing. Underneath better, as we start to go down from best to better, we start to go from bridging the gap between sterilizing something and disinfecting it. There's a very common chemical out there known as Sidex, which is in a lot of hospitals. That is absolutely probably a step between disinfecting and sterilizing, and that's obviously a chemical that you would be submerging your tools in. The problem with it is it only lasts a minimum of 14 days once it's open, but it is very effective. You only have to soak them for 60 minutes, and then you have near sterility. Formaldehyde is also another one that has been used, and that has actually been used at caches and in FSTs. The advantage of these chemical sterilizers is you can go beyond sterilizing just metal tools, and you can sterilize plastics. So if you have one Pleurovac and by chance you have a couple of unicorns on your deployment where you're putting in multiple chest tubes, you can reuse that Pleurovac by nearly sterilizing it in Sidex or formaldehyde. Formaldehyde you can buy in those small tablets. They have a much longer shelf life than the Sidex. 5% formaldehyde you only need to submerge your instruments for an hour, preferably 12 to 24. Maybe more is better in this instance, but an hour is what the studies have shown generally disinfects something. I want to just highlight one more that has always been talked about in austere settings, and that's bleach, right? Hypochlorite. A 5.25% use of hypochlorite, it also makes a Dakin solution, which I won't belabor that. That's in the CPG as well, but that's absolutely a good solution to use to irrigate a wound with and, continue your prevention of infection strategy. So it's a multi-use function. You can use it not only to irrigate and cleanse a wound, but you can also use it to disinfect your tools. I bring up dry heat. Another application for dry heat is an iron in a hotel room. It doesn't actually have to be in a hotel room, but if you have an iron and you can iron 100% cotton for 5 minutes on dry heat, that makes a sterile bandage. So pillowcase torn to shreds, put on an ironing board, and dry iron for 5 solid minutes with that high heat applied to it. you'll come out with a sterile bandage that you can use to pack wounds and do dressing changes.
Now you mentioned dry heat. When you're deployed, most countries you can find a pressure cooker. So you don't, as far as the lobster pot, I mean, that is a pressure cooker. So you got to look at adjusting so if you have less PSI, you need more time. Time, temperature, and pressure are what counts as far as sterilizing a pack. So you could use a pressure cooker and just adjust your time.
Yeah, thank you for mentioning that. That is the technique for using a pressure cooker is also in the CPG, and it's under the better.
So I think Justin brought up a great point that I like to highlight a lot with the guys is you can use things like pillowcases and do the quality ironing there and make sure that you get yourself a nice sterile bandage. In that, you'll also probably likely have bed sheets, which make for really good drapes. So just because you didn't originally plan to do surgery and you're in an environment that you're now finding yourself doing it, you can start to take a lot of normal household items and be prepared to do this properly.
Yeah, and the bandage, that very much circles back to, I guess, the overall philosophy for bandages. And we talked a lot about dressing a wound. What are your goals of a dressing? And that's sort of what you want to look at when we were talking about the saran wrap thing, vacuum. The overall goals of a dressing is very much to provide a barrier to the outside world. We talked about the wicking effect that we have on that, which generally leads down the road of a mechanical debridement if it's not too infected and there isn't a barrier of pus between the bandage and the wound. And then the mechanical debriding of it. That's sort of our goal for maintaining that infection management, mitigation, and prevention that we want to use with the dressing.
For today's podcast, be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.